I wish you all a very warm welcome to our session. So this meeting is being recorded, as you've just heard. It will also be available on our booth after this session. So here at FIND, we're seeking to ensure equitable access to reliable diagnosis all around the world. In the next 3 years, we're looking to save 1 million lives through accessible quality diagnosis and $1 billion in healthcare costs to patients and to health systems. Here today to share thoughts on transformative global diagnostic development and access, I'm really happy to be joined by several members of our team, including Dr. Daniel Bausch, who's the President-elect of ASTMH. So just a few housekeeping rules before we kick off. This is a very interactive conversation, so please do share your thoughts and questions as we go along. Just hit the Q&A button below. Share any questions in the chat and we will try and answer them as we go along. So first of all, let's hand over the floor to Dan. As well as being the ASTMH President-elect, Dan is, sorry, just had a small technical error there. As well as being the ASTMH President-elect, Dan is Director of Emerging Threats and Global Health Security at FIND. His distinguished career has been focused on the research and control of emerging tropical viruses across Africa, Latin America, and Asia, including Ebola and the SARS coronaviruses. He's held senior positions in the UK at Public Health England and the London School, as well as at WHO and the US CDC. So Dan, with that, I hand the floor to you.
Great, thanks, Sarah Jane. Nice to be with everyone this morning. Thanks to everyone out there, no matter what time of day, for joining, and a warm welcome from both ASTMH and FIND and from me. As Sarah Jane mentioned, I've had the opportunity and privilege to work in a lot of different contexts over the years, and for my career focusing primarily on viral hemorrhagic fevers and outbreaks of Ebola and Marburg and Lassa, and then SARS, the first SARS virus in Asia years ago, and things like that, hantaviruses in Latin America. And most of the time has been focused really, and we tend to focus as a society on the response part of this, and what do we do when something happens? And of course, that is incredibly important, and we're challenged now in looking at vaccines for COVID and therapeutics for COVID. But for COVID and everything else, we come back to the first most essential point is that you can't really do anything about treating a patient or treating a society that's sick unless you know what they have. And so that's one of the reasons that I've chosen more recently to join FIND and to focus on the diagnostics part of this, because it really is at the core of everything. And if we look globally, there was a recent Lancet commission, for example, that showed over 50% of diseases in the world are not diagnosed. So most people go through their lives suffering from things that they never know that they have or know specifically what it is. Sometimes they feel sick with a particular infection, for example, or a problem that they just don't know what infection it is. And then sometimes they don't even know that they're sick. They have hypertension or diabetes or things like that are not necessarily diagnosed, but nevertheless have ultimately a profound impact on their health. So the diagnostics are really the essential core of this. And then we think about what does it take to get diagnostics in place for populations. And of course, at FIND, our focus is on low and middle income countries. And we often focus on the technology. Technology is extremely important. And so there's research and development that needs to be done, developing new types of tests. But it's not only the technology. We have the other aspect of, first of all, access. If you don't have coverage, if you don't have a healthcare provider or access to a healthcare provider, then of course, even if you have the best test in the world, then you don't get diagnosed. So you need to have access. That's an incredibly important part of it. And one of the major focuses of FIND in recent years. And then there's also, and that entails many other aspects. So it's not just about having a great test. We think about it for FIND in low and middle income countries. You can have a fantastic test, and the technology industry can come out with a test that will diagnose everybody perfectly. But if it costs $100 a test, of course, it's not something that can be applied in most low and middle income countries. So lots of issues about the technology, the access, and then the price points. And so a lot of work to do, but also, and then I'll hand it back to you, Sarah Jane, and the other speakers, but also an incredible opportunity. So we are seeing a sea change, I think, in the last few years, decades, and then accelerated by COVID, in terms of the technology part of this has really come on strong. I remember being a medical student in the late 80s and a resident in the early 90s, and this new thing called PCR was coming out. And we said, wow, PCR, what's this? And now, of course, we take that for granted, an incredible, powerful tool. And it's gone further. We have genomic surveillance and full genome sequencing, and we have rapid tests and really lots of important and promising technologies. And our challenge is to, of course, continue on that, but put them into play and give people access to get the maximum impact. So I'll stop there, Sarah Jane, back to you.
Thanks so much, Dan. So the other team members that we have on the call with us today are Cecilia Ferreira, who leads our AMR program. We have Yuvanel Karamahame in our FEVA team, and we have Kavi Ramjeet, who leads our technology program. So as I mentioned, if you've got questions, please don't hesitate to pop them in the box and we'll see if we can get to them. But let's kick off by talking about the biggest challenges in diagnostics. So perhaps Kavi, you could start us off.
Yes, thank you, Sarah Jane. So I think first of all, really pleased to be sharing a couple of insights into technology and the perspectives, and thanks to ASTMH as well for inviting us today. So there are definitely a lot of challenges when it comes to IVD and to address the different needs, in particular for LMICs. But I wanted to focus on a couple of challenges. I would say probably not call it challenges, but things that we need to improve in the next coming years in order to address all the needs. So it would be around, I would say, how to bring highly sensitive point of care assay and platform down to NMICs. We've been working a lot on different diseases around this, on TB, HCV, malaria, and I guess to be able to bring those sensitive platform at the point of care level is today still a challenge, because you need to bring that high complexity platform that you have in big labs in a miniaturized version into LMIC. So this obviously can be done, but to the expense of a higher cost in those different assays. What's important as well is to be able to look at the different platforms more in a multi-pathogen, I would say, approach. So mostly looking at multiplex platform. So we need to be able to bring those multiplex platform to look at things in a more syndromic approach. When it comes to point of care platform, there is the portability aspect and battery operated features as well that we need to be working on in the next coming years. How do we make sure that we bring those platforms into the community, into primary healthcare, and make sure that they can be used there, in particular in settings where electricity, for instance, is not accessible for everyone. One other thing is about the collection method, because we think about the technology, but once you have the assay, it's important as well to focus on the different collection devices, make sure that we do have a proper samples that is easy to collect for the different population, thinking mainly about children, for instance, where, if we take the example of SARS-CoV-2, where we had nasopharyngeal swab, and then we had some tests that developed on nasal swab, but also at the end, more on saliva tests. So we need to make sure that we can have technologies that can work on simple sample, but at the same time, keep the same accuracy and performance. So we have a couple of activities on this. And maybe last point on those technologies is about the operation in different environments. As you know, most of those platforms have been developed for high income country use. And when it comes to operating temperature, resistance to dust, operating in different humidity conditions, we need to make sure that we work in the future years on this, and this is a challenge today. So I'm going to stop here, but maybe to conclude on the technology perspective and the challenges, we also need to keep in mind that we don't have one single technology, one fits all solution. So we need to make sure that while we develop those technology to address those different gaps, we do have also existing technologies, and we need to make sure to choose them appropriately for the different use cases, whether you're looking for triage tests, a confirmatory test, or a surveillance test, but also that they are really well adapted to the different settings. whether you need a point of care solution or a more high throughput lab-based solution. So I'm gonna stop here and maybe hand over to Cecilia.
Thank you very much, Kavi, and thank you, Sarah Jane and Dan, to make possible this booth. I think it's really important to highlight the importance of diagnostics in general, especially during COVID times, right? And when it comes to the clinical perspective, there are several challenges around diagnostics, right? And I think Kavi mentioned how challenging it is to bring a technology that normally will be sitting in a lab to be working in a primary healthcare level in a low and middle income countries where sometimes there is not even running water, right? So from the technology perspective, there are huge challenges to make those solutions easy to use, affordable, but also from the clinical point of view, there are several challenges, in particular in decentralized sites or rural areas, we can say in low and middle income countries, where there are very few human resources. And when I say human resources, I say in general, right? I'm not talking about doctors. It might be sometimes only a person who has been trained on some clinical management. And this person will be the one not only seeing the patient, but also doing the training of other people and doing the diagnostic test. So there is, and I think the lack of human resources to basically a primary healthcare level is one of the main challenges when it comes to diagnostics as well. Most of the people don't ask for tests, basically because sometimes they are expensive, more expensive than a treatment, right? And if you need to ask for a rapid diagnostic test that will cost $2 perhaps, that's more expensive than a course of antibiotics that will be less than $1. So there is a lot of lack of understanding as well of how diagnostics can also make patient management more cost effective as well, and how this can save and protect antibiotics, for example, as well. And speaking of which, we are in the middle of the World Antimicrobials Awareness Week. And I think this is really crucial right now to talk about diagnostics, how to make them simple to use by clinicians or lab tech that won't be really trained on how to use sophisticated technologies, right? And then there is a very important point that myself, I've seen as clinician on the field. You can have those diagnostic solutions, and let's say that Kavi can do these beautiful small machines, cheap to use, robust for very high temperatures. But sometimes there is a problem of communication between the diagnostic people, the people who is in lab, and the clinicians, right? And this could be this is a really a big challenge, but I think it can be easily overcome. So sometimes what you can see is that the time to provide back the results, even if the machine went really fast, let's say the result, you get the result from a machine in 30 minutes, but sometimes something happened there, and the clinician would just get the result 2 hours later or the day after. And the second challenge also is that not always the clinicians can interpret the results. So now I got the result, what I'm supposed to do. So I think also linking diagnostics with training of people and capacity building is also crucial to make sure that those diagnostics that we are developing are used and accessible for most of the countries. Hand it over to you, Sarah Jane.
Thanks so much, Cecilia. So, I mean, I think that these are really interesting and important points to address. But one thing that always strikes me is that patients don't present with a disease. They don't turn up to the doctor's office and say, hey, I've got tuberculosis or I've got malaria. They present with a symptom. They say that I've got a cough or I've got a fever. And differentiating and making sure that the right disease is actually being treated has got a huge amount of challenges associated with it. So how do we deal with that? Perhaps you, Bernal, you could talk from the fever perspective.
First, I wanted to reiterate what Kavi mentioned about the challenges that are to do with diagnostics, especially in the resource-limited settings. In the AMR diagnostics study that we are operating in low-income countries, Ghana, Uganda, Burkina Faso, and in Asia, Nepal, and India, one of the challenges that has been raised every now and again by the teams is that whereas we are using commercially available point-of-care tests to, leverage a diagnostic algorithm and better manage fevers and reduce unnecessary prescriptions, these tests are actually not suitable for the local environment. For instance, one of the major issues they've raised in Burkina Faso is that the temperature is too high for these tests. So they have to always use a kind of cold chain system. Tests have to always be they have to install AC, air conditioning, so that the tests don't expire very fast or get unusable. So it's a major challenge, and if we are engaging developers aiming to have these tests being implemented at the lowest level, at the poorest of the poor communities, then they should be tailored to these conditions. So to the question regarding how we can leverage the new diagnostics, the new innovations in fever management, one of the strong points that African communities have relied on in health management is community health workers. Most of the countries, the first level of healthcare is what they call a village health team, or a sort of community health worker. So these are the people who move from house to house, and then they interact with the people, they know them, usually by name, and they are members of the community, and they are usually the first point of contact in case, for instance, for fever. And as we know, fever is one of the commonest causes of visits to the health facility. And however much these fever syndromes tend to recover very fast, some of them progress to severe disease. So using new technologies, using mobile health, and then leveraging that together with this robust network of community health workers, we could better manage fevers, that is, early detect fever illnesses at the community level before they escalate to serious illnesses like pneumonia. So I think that is one of the points I would want to reiterate, that we could use these new innovations, digital health, and within these countries, internet usage is increasing, mobile smartphones are now widely available. So if these community workers could use point-of-care tests that are tailored to the community, then combine that with mobile applications and so on, that probably leverage diagnostic algorithms which do not need extensive medical knowledge and skill, we could have these patients detected at the earliest level, managed at the earliest level with accuracy and efficient means, and then this would feed into the national surveillance program. And lastly, at the global level, this could actually also improve disease surveillance globally. Thank you.
Thanks, Yuvenel. So Kavi, how close are we to some of these technologies and the digital tech that Yuvenel was just talking about?
Yeah, I think, thanks, Yuvenel. I think we need to look at those technologies in two different ways, right? Because when it comes to management of the patient, especially in a syndromic approach, we have a couple of tools already available. Obviously, as mentioned at the beginning, we have those issues about temperature that we need to fix, because not all those technology can be operated in LMICs, for instance. But we have a couple of tools that are available. We need to find the appropriate way to bridge those different tools together in order to have a good sequential way of using those tests in order to be able to manage the patient more effectively, I would say. So have a nice workflow. On the other side, obviously, we're working on some new technologies. In particular, I mentioned that at the beginning. We have put a lot of efforts in the past few months to work on accelerating the development of multiplex point-of-care platform. I think this is where we can bring a real impact into addressing the syndromic approach, where we could be working on and detecting different diseases at the same time. So we are mainly focusing at the moment on COVID-19 plus small panel of respiratory pathogen, but we do want to use that as a foundation, as a basis to develop some other tests detecting multi-pathogen for, I would say, fever management, but also different syndromes, whether they are respiratory or any other kind of syndromes. So obviously we need the digital part. So we are looking at those platforms and looking at the connectivity aspect of those platforms as well, in order to be able to transfer those data for AMR surveillance, for instance. So this is something that we are very involved in.
Brilliant. Thank you very much. Oh, I was going to say, I would like to make it back to you now, Dan, if that's okay, because we talked a little bit about surveillance, about pandemic preparedness. FIND is also part of the Access to COVID-19 Tools Accelerator. Perhaps you could tell us a little bit about that.
Yeah, sure. I'd be happy to. I just wanted to reiterate the point that Kavi made, that I think it's an extremely important one. And that is, it doesn't necessarily have to be a single assay that's multiplex. It can be an algorithmic approach to get to multiple diseases, but it really needs to be the focus, I think, going forward of diagnostics. Too often we're sort of focused on a very binary approach of does someone have Ebola or not? Does someone have COVID or not? And I can tell you from, both as a clinician and as an epidemiologist and in the field, if you go to the patient when they're sick, or you go to the Minister of Health when an outbreak is going on and say, good news, you don't have Ebola, or the outbreak's not due to Ebola, they are happy for about 10 seconds, and then they wait, of course, and they're waiting. And because what's of interest to them is not what they don't have, it's what they do have, right? And so you're still sick with something. And so the doctor telling you, you don't have Ebola, you're happy about that, but you'd still like to know what you do have and get treated for what you do have. And the Minister of Health, he or she would still like to know what's going on and how to manage that. So that is an incredibly important part of what we need to do, and get beyond a binary approach to really down to what it is and not what it's not. And then we come, you asked me to talk a little bit about the ACT-Accelerator and the work that FIND's doing as a co-convener. If you're not familiar with the ACT-Accelerator, this is something that's been put together in response to COVID, to bring WHO together with various partners and expertise around the world to try to manage in a cohesive way the response to COVID. And so there's parts of this that are relative to diagnostics, and then broken up into working groups for genomic surveillance and country implementation and a lot of different groups. And then other parts that are related to therapeutics and vaccines. Everyone's familiar with the COVAX facility, for example. So we have been part of the co-conveners and with the diagnostics group, and I've been especially involved with the genomic surveillance working group. And one of the activities, for example, that we've been able to do through that is a mapping of capacity for genomic surveillance around low and middle income countries, to get an idea really where is the capacity and where are the needs that we need to, with many other partners, of course, try to support. Extremely important, as you know, in the COVID era, for not the primary diagnostics so much, but the genomic surveillance capacity, of course, is incredibly important to know which SARS-CoV-2 viruses are circulating. Is it the Delta variant? And especially concerning, of course, the idea that do we now go on to other variants that are equally or more transmissible, equally or more pathogenic and make you sicker, or in the worst case scenario, and of course we hope to never get there, but variants that are not covered by present vaccines and new therapeutics. So some of the work that we've been doing, and then to touch upon pandemic surveillance. So of course we're in the midst of a pandemic. This pandemic is far from over. We do need to remember that, and it's far from over even in high-income countries, but even further from being over in low-income countries. And as I think everybody on this line knows, and I'm sure all our listeners know, it's not really over until it's over for everyone. And we're all connected in ways sometimes that we realize and sometimes we don't. But that's a major focus. But we need to use COVID-19 to leverage and really, if I can be a bit idealistic, a sea change for diagnostics. And in that there's an opportunity with everyone focusing on this disease, and some of the diagnostic tools that we have. 2 years ago, no one knew what a rapid diagnostic test or RDT was, or very few people. Now everybody in the world knows, oh, that's the one where you put it on the strip and you wait for the line to show up. I mentioned the emphasis on genomic surveillance, and shoring up genomic surveillance. Incredible potential and the need right now urgently for COVID, but incredible potential for TB, for antimicrobial resistant organisms, for many other things. And so there's a lot of added benefit for what we're trying to do in leveraging this incredible response for COVID to many other diseases. I'll maybe come back to that a little bit later if we have time, but I'll stop there for now.
Thanks so much. When you mentioned antimicrobial resistance, which has often been called the silent pandemic, Cecilia, do you want to talk a little bit about that?
Yeah, and I think as I mentioned before, right, diagnostics and antimicrobial resistance are really linked, and there are a couple of things that have already been mentioned by Juvenal, right, or by Dan. When you are on the field and when you are seeing a patient and you are telling a patient that he doesn't have Ebola, of course he will be happy, but then the patient wants to know what they have, right? And I think historically we have been trained as a clinicians to do a responsible use of the diagnostics and resources as well, right? And that came more and more because the systems, the public health systems, suffer a lot from, and I'm talking not only about low and middle income countries, but also high income countries. And you have to explain why you are ordering a CT scan, a pulmonary X-ray, or a diagnostic test. And I think we got so used to antibiotic prescription just in case or by syndromes that that's going to take a long time to change the paradigm. And I agree that Dan, I don't know how many rapid tests people have seen before in high-income countries, right? I think low and middle-income countries, they are pioneer on that. They've been the advances that they have compared to high-income countries. HIV rapid tests has been used in low and middle-income countries for more than 25 years, and they came to high-income countries 10 years ago because they believed that PCR was better. So there is a lot also to be done in terms of how do we dismantle this paradigm that is about saving resources, spending few on diagnostics, because you have this antibiotic that is going to be cheaper. The problem is that these antibiotics are not working anymore for some diseases. Like, and just to give you an example, for a very common sexually transmitted infection, which is gonorrhea, there are around 10,000 new cases per day in the world, right? And that's big, but people don't die of gonorrhea. But you have one treatment that is ceftriaxone, that the vial might be less than $1, so the treatment is really cheap. But this drug is really useful for other diseases like meningitis, pneumonia, and it's an injectable drug. So why are we using an injectable drug for a disease that could be managed at a community level? And the main reason is because we don't have diagnostics for gonorrhea right now. And when I say we don't have diagnostics, we don't have easy to use, fast, and cheap enough to be used at the point of care. So what are we doing? The easy solution is let's continue using antibiotics. But now gonorrhea has become resistant, and rates of gonorrhea resistance are increasing and has become, and is a star now. This guy is in the WHO priority pathogen list, and we are not taking actions around that. And there are many other bacterial diseases for which we are running out of antibiotics. Typhoid, for example, is a disease that is very common in low and middle income countries. And it used to be very simple to manage an outbreak of typhoid. But now it's become resistant to the first line that we are using for antibiotics. So it's time to start thinking on the equation how diagnostics can prevent antimicrobial resistant development by making sure that when we give a patient antibiotic, it's because the patient really needs that antibiotic that we are prescribing for the duration that should be. And I think AMR is not only about diagnostics, right? But it's one of the main pillars. And as Kavi mentioned before, you need to have these tools really simple, cheap, and available to be used. And then all the challenges that we mentioned at the beginning, right? If a facility doesn't have running water, people cannot wash their hands. And that's a key priority for AMR as well, to prevent the transmission. But diagnostics, and I have been shocked to let you know, I have been shocked in the last few days, was presented in the AMR call for action. And I was talking about people really very passionate about AMR and asking for new antibiotics. And I didn't hear much about diagnostics. So, and I always wonder, like, why are we asking for new antibiotics if we are not yet able to protect the few ones that we have? And that the only way to protect those antibiotics are with diagnostics. And I will stop here because I get very passionate about the subject.
Thanks so much, Cecilia. I mean, we've talked a lot about actually the diagnostics themselves, the tech that we need. FIND is working obviously across the whole spectrum, right from R&D through to access, implementation, etc. So perhaps we could just talk a little bit about some of what the work that we're doing on the access side. Kavi, perhaps I could go back to you. It's not just about the tests, the technology behind the tests, but also about how we're manufacturing them, right?
Yeah, thanks, Sarah Jane. I think COVID-19 in 2 years has been a big, I would say, fast track lessons learned on what are the main challenges when it comes to implementing, developing and implementing those different tests, more globally, but more particularly in LMICs. So we've had, when looking at those lateral flow assay, for instance, but also for molecular challenges in accessibility, distribution. There were some import-export issues. There was the notion of the cost of the test that weren't affordable necessarily at first, the availability of raw materials, and taking all this into account, FIND has really focused on how we can really strengthen the local capacities in LMICs, and in particular looking at local manufacturing capabilities. So we have been in the past year investing together with other partners like Unitaid in manufacturing capacity in LMIC, in particular in Africa, in Latin America for lateral flow assay, investing in infrastructure, buildings, equipment, but also making sure that we support those different I would say companies and suppliers in terms of technology transfer to put together the quality management system. So the main idea is not only looking at COVID-19, but it's to prepare a solid foundation for other diseases and to be a little bit more proactive moving forward for unfortunately future pandemic. So I think we need to keep moving, and we need to expand that action to other countries in LMICs, but we also think the next step is also to look at how we can expand that to other type of technologies as well, right? We've been doing that for lateral flow assay, but now that I've discussed about our effort that we're doing in the point of care molecular side, we need to be thinking of how we can also support manufacturing and capacities in low and middle income countries when it comes to molecular solutions as well. So I'm just going to stop here and hand over to Dan.
Okay, well, what are you handing over to me for?
Perhaps we could pick up a little bit on, I mean, Kavi mentioned the rapid tests, you mentioned the point of care molecular tests. Perhaps you could talk about why we're focusing on some of these more decentralized testing opportunities.
For me, Sarjane, yeah?
Yes, please.
So I think, as I mentioned earlier, we really do need to change the whole paradigm, I think, and I do think there's opportunity to do that if we can stay focused and recognize the value, and Cecilia just gave great examples of that, of the value that we need to appreciate, and that we're spending money on developing new antibiotics that we wouldn't necessarily need to spend, and if we could just shore up the diagnostics so to use those wisely. So we need to have diagnostics be at the core of that, and there are different approaches. You know, we tend to think that diagnostics are something that happens when you go to the doctor and say, I have this problem, and so they take your blood or a swab or whatever it may be and send that off and you get an answer. But that's not necessarily how things need to work. And one of the the problems with that, of course, is it can be slow, it can be expensive, it's centralized, it requires access to care, it requires access to a laboratory. So there are approaches, and you mentioned self-testing. So there's an opportunity to put the patient really in control of this and be able to diagnose at home in a much more convenient and potentially cheaper way what they have. Doesn't mean that's not the end of it, of course, but nevertheless, if you can go to the store or the market and get a cheap diagnostic test and then find out relatively fast what you have without having to go through a whole process, we can imagine that would fundamentally change the system. There are other challenges that we need to work out through that. How does that work in terms of surveillance, right? We're used to surveillance systems that are dependent on laboratories that add up all the positives and send it to an agency within a government and then perhaps on to WHO. And so we say these are the number of cases of X, Y, or Z in the world. And we don't necessarily get that through self-testing, but we do have an opportunity for people to be more in control of their knowledgeable and in control of what they have, and then act on it in a more rapid and potentially efficient way that can prevent things from getting out of control. As Yuval mentioned earlier on, that community approach and individual approach, so that we don't have to respond to big outbreaks because we've handled them when they were small.
Great, thank you. Cecilia, perhaps I could just pick up on something that Dan said about when we've got these decentralized tests and we're used to having laboratory situations where they can centralize the data and then they can make them actionable. How do we need to adapt, or how do health systems need to adapt in order to be able to deal with these more decentralized testing approaches, including self-testing?
I think this is a very interesting question, Sarah Jane, and I think I will mention again the example of HIV, because I think we've learned a lot from that pandemic, good and bad things. But I think most of the countries are having already surveillance systems, let's say, which might or might not include diagnostics always, right? And I think with HIV there was a time where just number of cases being reported, and that number of cases, like COVID right now, right? Like you are reporting how many cases are positive. But then that becomes bigger and bigger, because every time there were more people being diagnosed on HIV and they started on treatment, which means that those primary healthcare level and facilities, they needed to reinforce their capacity. So there was like, donors were supporting a lot of countries to build resilient health systems, to have more trained staff, to shift some activities, right? Like you never saw, there hasn't been any other disease that has said now a test doesn't need to be done by a trained lab technician. Now a community health worker can do a test if it is trained. So there are so many good examples from HIV that could be used not only for COVID, but for AMR, for malaria is also working on the same way. Systems are adapted. The problem is, as in many other areas, right? We work on silos, and the countries also work on silos. So if the TB program or the HIV program is doing huge efforts, there is no COVID program. I don't know what would that be, and I would really like to hear from Dan about that. There is AMR action plans right now, but the thing is, how do you make sure that all those disease programs work together at a cross-cutting level? How they make decisions at a primary healthcare level as well? Can we use some of the data that has been used for COVID for surveillance purposes, not only for COVID, but for other respiratory tract infections? And I think the answer is yes. You can learn a lot by having diagnostics, decentralized diagnostic use if you are able then to compile that data and to make sure that the data is being used. And I think also I will just give a bit snapshot on digital solutions, because I think more and more, and Juvenal was also mentioned, that digital solutions will play a big role in the future. They are already playing a big role. And you know, the example that we have with a software, a digital toolkit that was connecting all the AMR data surveillance from the One Health approach. So it was animal data, agriculture data, and human data. And that data was all digested in one system. And that was just sending the data to HUNET and to the GLASS report, but also giving the country a dashboard with actionable data, right? Because countries are the owners of the data, and they need to have that data to make decisions as well.
Great. And in fact, you've just answered very nicely one of the questions in the chat about the role of digital in the future of diagnostics. But perhaps this is a good time to come back to you, Juvenal. You know, we've learned a lot about diagnostics and the power that they can have, especially in decentralized, when used in a decentralized way through COVID. When it comes to fever management, what's your sort of big wish for the future? What do you think we could, you know, what's the potential that we've got for fever management and using digital and lessons from COVID? It's a very open question.
Thank you very much. I think one of the exciting things about COVID-19 has been a bad thing, but it has come with some positive things, and one of them is the scale up of genomic surveillance and sequencing in Africa. So I think I know WHO, of course, and FINE, like Dan has already mentioned, work is already going on to improve the genomic sequencing capacity in low-income countries, especially in Africa. So I think if we can do this and expand the capacity, the skills, the knowledge at the lowest level of the health system, then we could improve costs of diagnosis, treatment, and surveillance of all diseases. Not only COVID-19, but other infectious diseases, other pathogens, and then we could actually look at variants. But like COVID has already shown, with genomic surveillance, you can quickly pick up these variants and respond to control. And you know, in the past, for any genetic sequencing you needed to do, you would have to send samples abroad to Europe or to USA. And definitely this was very costly for research programs, it was costly for surveillance program, ministries of health, and so on. So with this capacity built on local soil, one, you have costs reduced, but then there is also the issue of trust. In the past, patients, study participants, they would always have this question of, why are you taking my blood to another country? Why don't you test it here? So with this capacity built within these low-income countries, low and middle-income countries, we are going to have these solutions, these challenges kind of partly solved. The other interesting bit that has gained traction during the COVID-19 pandemic is the use of artificial intelligence, real-world data, and then the use of devices, diagnostic instruments with remote connectivity. So I've seen a paper, actually, it is a post at the ASTMH, and they are looking at how to use artificial intelligence to monitor cough data using a mobile smartphone app, and then use that data that is collected to, in real time, detect respiratory diseases, and then, you know, link up with the health system, the ministries of health, disease control programs, and actually do real-time surveillance of diseases. So if all this could be taken up by, you know, ministries of health and other partners, we could actually improve the number one, detection of disease, then early treatment, and then surveillance and disease control at the national and even global level. So those are the two exciting things that I would want to see moving forward and becoming large scale.
Great, thank you so much. Kavi, on the technology side, what are you super excited about?
Yeah, I think what was interesting to observe is that the impossible became possible, right? When you look at those different technologies, thinking of, we've discussed about the point of care platform, for instance, where first 2 years ago, when we were looking at the landscape of those different technologies, and if we look at the landscape now, it's completely different. We've seen so many companies being able to pull this off and provide, let's say, a SARS-CoV-2 test commercially available. I think thanks to the governments, the funders, also the synergistic action of the global health actors, as Dan mentioned earlier about the ACT-A consortium. This was really important for all those organizations to work together towards a common goal and common objective, and to be able to really support development in an effective way of those different platforms. So when we look at the different advances, obviously I just discussed about point of care platform. My colleagues here just mentioned the digital solutions, looking at medical devices and softwares. We've been working for several years now on computer-assisted detection in the field of TB, but we're also looking forward to investigate these a little bit for COVID-19 as well. When it comes to digital devices, medical devices, we have digital oximeter, we have cool technologies, recording cough sounds and linked to some AI-based software that can help to actually, that can support the detection of those different diseases. And same, it's been mentioned for digital solution, we can also think of all the advances made in the data transfer for surveillance to inform the different countries and the national programs on what's going to happen, what's happening, and to anticipate a little bit on eventually potential epidemic or pandemic. So I think there's been a lot of work and new advances done in those digital solution. I wanted to mention as well sequencing, right? Because sequencing, been working as well on this on the TB front, but we've seen with COVID-19 really an increase in implementation of sequencing technologies in LMICs, in particular when we think of COVID for variant detection, epidemiological analysis. So this was really interesting. What else? I think self-testing, Dan mentioned the self-testing. This is an important aspect as well, because our objective is to be able to cover the different population, and it's really important, as Dan mentioned, to empower the patient in those different health issues, and to actually facilitate access through the self-testing. And maybe last, Sarah Jane, I wanted to mention that we need in the next coming years look at this in a more eco-responsible way as well, because green diagnostic is something that is definitely in the news, obviously at the moment, and we need to be careful about this. There are a lot of companies that have started work on how to better manage the waste, how to reduce the plastic parts and toxic materials in their different products. So we need to be considering this moving forward, and make sure that we're bringing the appropriate, accurate diagnostic tools to the population, but also being mindful that we need to take care of the planet and also the population. So I'm going to leave it here.
Absolutely. Thanks so much, Kavi. Thank you. Cecilia, what does all this mean for AMR when you look to the future? Are we making progress?
I think I'm gonna be like Juvenal, trying to take the positive side of COVID, right? And I think we have to do it also to build resilient populations as well, right? And I think as Kavi has been mentioned, I don't think we've ever seen such a number of new technologies popping out, right? What has been done during the COVID times is unique. And I really wish that could happen as well for AMR. So for me, the lesson taken, the positive lesson learned from COVID is possible. We see that it's possible. What happened in the last few months has unprecedented. We've never seen something like that. Having a diagnostic solutions, having a vaccine. Now there are some future on the treatment. And I really wish this could be applicable to all the diseases and to all the problems, in particular because AMR is here, is happening. And I think that once countries decide to report the deaths of AMR, that will change. When you start hearing from your friends that your mom, your grandma died of an resistant disease in a hospital, that's when people will realize where we are. But this is already happening. And I think there is a really positive for the future. In terms of diagnostics, also what happened during COVID is at the beginning, in the first 2 waves, there were so many hospital admissions, and hospitals were really crowded. And there are now a lot of reports on how many nosocomial infections were acquired during that period and how much antibiotics were consumed with or without evidence of a bacterial infection. So I'm really optimistic that AMR will be highlighted as an existing and silent pandemic. And I hope that all the developments on technologies, on vaccines, will also be sustained for AMR in the future.
Absolutely, absolutely. And so, Dan, what about pandemic preparedness more generally as we move forward? So there's been lots of lessons learned from COVID. We've talked obviously about genomic surveillance. How will we be better prepared next time?
Yeah, so that's a key question, of course, and lots of focus on that. And we've seen as COVID has gone on, people thinking, of course, still about COVID, but then about how do we avoid the next COVID, right? The next coronavirus or whatever it may be. And various structures and frameworks that have been set up to do that were involved. And we've already mentioned the ACT coordination through WHO and partners. But also there's the new pandemic surveillance network. There's one of the things that I've been working on a lot lately is something that was proposed coming out of the G7 meeting in the UK recently, and the 100 days mission for pandemic preparedness, which is basically a challenge that within 100 days of WHO declaration of a public health emergency of international concern, that we would have diagnostics, therapeutics, and vaccines ready to scale up. An incredible challenge, if you will, kind of a moonshot challenge, and something that will take incredible energy and resources to do. But and where I see the opportunity for that, and where I've also seen the mistake made in the past, is people put together pandemic surveillance systems based on the aberration and based on the thing that rarely happens. And so when there's an Ebola outbreak in West Africa, people afterwards say, okay, well, we need to put in laboratories to detect Ebola for the next time. And the problem, of course, is these things are rare, and they're devastating when they happen, but Ebola outbreaks are rare. SARS entry into humans, the initial entry from animals into humans, is a rare event. And so if we base pandemic surveillance on those sorts of rare events, it never really works, because you'll invest a lot of resources and a lot of energy, and then you say, okay, well, now there's a rapid test in a community health clinic for Ebola, and everyone who comes in with a fever should have the rapid test. And the community health worker will do it for 1,000 or 5,000 tests, and it'll all be negative. And then you say, why should we do this? Always negative. Or the government will say, why would we pay for those tests? Because it's always negative. So essential in the pandemic preparedness is really to build systems. And we talk kind of the colloquial terms about, the horses, the common things, and the zebra, the uncommon things. So it can't be focused on the zebras. It needs to be focused on the horses. It needs to be so that a patient and the hospital and the government say, this system is worth investing in, because every day it helps us. Every day it picks up the patient who has an antimicrobial resistant organism. It picks up someone who has HIV. It picks up the TB and the respiratory disease, the pneumonias that are common, and then builds a capacity that can be transferred to pandemic pathogens if and when they occur. And so that's That's not easy to do, and it requires lots in terms of manufacturing capacity, regulatory agreement. We talked about many of the other things, the digital health, the technology, the R&D, all this needs to come together. So we're right at the beginning phases right now of trying to put this all together in a system, again, that needs to be oriented towards, if I can say it this way, what ails you in a more day-to-day or week-to-week manner, but then allows us to build a system that can approach pandemic pathogens when they occur. So that's an incredible challenge, but it's an incredible opportunity, right? Because if we do that, then it helps the horses. It helps diagnose the horses and treat the horses that are occurring all the time, and it floats all of the boats and all the systems to a level that can deal with many diseases and not just the rare one when it occurs. So that we'll see how that goes. But again, incredible challenge, very complex, but incredible opportunity.
Absolutely. Thank you very much, Dan. So there's one other question in the chat that I don't think we've addressed yet, which is around the supply of COVID diagnostics that we've seen, and whether or not that's going to have an impact on supply of other diagnostics in the future. Perhaps Kavi, you could start, and then maybe Dan, you could come in.
Sorry, I was on mute. Yes, Sarah Jane, I think to that question, we've done a lot of effort to be able to increase the supply of diagnostic tools, in particular SARS-CoV-2 tools. We do want to use that as a leverage for other diseases. As I mentioned at the beginning, we've worked on local manufacturing capacity. We're trying to secure as well, local availability of raw materials, because this has been a challenge not only in MICs but in high-income countries as well. Everyone's heard of the different shortages that we had, extraction kits and so on. So overall, I think it's going to have a pretty good impact. We need to keep in mind that COVID-19 was a pandemic, so a lot of companies have really increased their manufacturing capacity to be able to address the different volumes needed. So we need to build on that, right? We need to keep that capacity and find a way to use that capacity for other diseases as well once the pandemic will be over. So this is a challenge, and we need to make sure that we keep enough supply for other diseases as well moving forward.
Totally. And so Dan, maybe you could talk also about the supply of self-tests and how much of a game changer it would be to actually have self-tests available in local pharmacies.
So two aspects, I guess, to build on what Kavi was saying. One of the challenges has been that manufacturing for diagnostics and almost everything else has been very highly concentrated in high-income countries. And so when we have an emergency, low-income countries are dependent on those countries to share. And we've focused, and this is most, people are most aware with regard to vaccines and the equity arguments that has been made. But we have, let's say, modest success in terms of that equity argument and sharing. And so one of the keys for the future is to have more autonomy that's distributed across low and middle income countries. And so if you're in West Africa, you can produce a vaccine or a diagnostic or a therapeutic on your own and have for your region, rather than depending on that coming from a distance. And then that goes for self-test as well. And so I think we need much more local solutions to this, local production, and then it's not one size fits all. And so how self-tests, how rapid diagnostic tests would be used in a given community might not be the same in Kampala as it is in Kinshasa, as it is in London or Geneva or New York. And so I think we need to have a localized capacity to not only produce, but also to then how they would be effectively used.
Absolutely. Thank you so much. So I see we're just coming up to time. So I think perhaps at this point we should thank all of the panelists, all of my fine colleagues for taking the time to be with us today. Thank you to everyone who joined us on the booth. We do have several activities ongoing at ASTMH, as well as our virtual booth. There's also a number of poster presentations and oral presentations. Dan, of course, is President-elect, so is involved in so many of those things. I think we have a slide as well that we could just show with a couple of other initiatives coming up. Cecilia mentioned that we're in the middle of World Antibiotic Awareness Week. So we have some activities related to that as well. Do we have the slide that we can just pop up to show the different activities? Perhaps we've had a technical issue there. Unless anybody else can see it, I can't.
No.
Not to worry. So I think with that, then perhaps we can just clarify that on our booth there will be all of our activities on there, including our World Antibiotic Awareness Week. Oh, here we are. Here we are.
Yeah.
So there's a fever video series that we're launching. That will the first in that series will be coming out on the 24th of November. So that will be on our website. Right now, you can sign up on the website to be able to be notified when the first one is available. And for World Antibiotic Awareness Week, we have a couple of different things going on. Cecilia, that we've met today, will be talking on a panel from the AMR Industry Alliance, and also our CEO, Bill Rodriguez, will be on a panel on Monday about how we can handle antibiotics with care, which really speaks to what Cecilia was mentioning earlier. So both of those links you can see on your screen now, and we'll put them in the chat, and they're all on our website as well. So with that, I think perhaps I could just hand Dan the last word, and we can close the session. Thank you very much, everybody.
Thanks, Sarah Jane, and thanks everybody for participating, the panelists and all of you tuning in. I'll close kind of with wearing my two hats. So first, from the FIND perspective, I'd just like you to encourage people, especially if you're listening, if you're a younger investigator or student, this is a fascinating field to get into, and you may think it's just about the technical part, and if you're not a laboratory person, why would you get into diagnostics? But I think that, and hope that you've seen today, that it's incredibly broad, that there's aspects of the epidemiology and the clinical trials, and sure, the technical part and laboratory people, if you will, but then access to care. So it's incredibly broad and incredibly challenging. So if you're interested, please do. I'm happy to have you reach out to us if you want more information. It's an important field and an interesting field, and so think about that. And then of course, from the ASTMH standpoint, I hope you've been tuning in, enjoying this meeting. We very much hope to be in person, but also online in Seattle next year around this time. And so please join us at ASTMH for the meeting, but also take a look at the society if you're less familiar, and their activities throughout the year. So thanks very much. Have a great day, everyone.